So my name is Chadi Nabhan. I am a medical oncologist and a hematologist. So I have treated and took care of patients diagnosed with cancer for almost 2 decades. And I have been with Caris Life Sciences for the past 3.5 years. At Caris, I hold the position of Senior Vice President and Chairman of the Precision Oncology Alliance. As your viewers, listeners, and as you know, probably Caris is a molecular profiling company. We really are pioneers in the area of precision medicine, molecular profiling, as well as applying data science and artificial intelligence into the molecular information in order for us to answer questions that are very difficult to answer without this technology and without these advances. So the Precision Oncology Alliance is a very large and expanding research network that brings in academic institutions and healthcare systems from across the country and the globe that have a shared vision of really utilizing big data and precision oncology and biomarker research into questioning, asking the right questions and having answers across various and all cancers. And right now, our network is 85 institutions, and that actually includes a cooperative group as well as a research consortia. And these 85 centers include 55 academic university-based centers and 40 comprehensive NCI designated cancer centers. Now, with that scale, we actually divided the Precision Oncology Alliance into various working groups and disease groups that really, these working groups are tasked by really mining the data that we have and try to look at the type of questions that might have significant impact on advancing the work of that we actually have. So with that, we've had very nice productivity at various ASCO meetings. And this ASCO, the ASCO 2023, we have 42 presentations. That actually includes 3 poster discussions and 1 oral presentation. As probably your viewers and listeners would appreciate, it's going to be impossible for us to review all of these. So maybe I'll highlight a couple, I think, that may at least give you a flavor of what we try to do. I think one of the abstracts I would like to highlight, which I really think it embodies the art of artificial intelligence, big data, and biomarker, is what we are calling, it's a brain metastases predictor. So as you know, many patients with solid cancers might develop brain metastases with time as the cancer comes back. So we actually looked at our data set and we were able to identify a predictor that would tell us with a very high degree of precision patients who are at the highest risk of developing brain metastases versus those who are at the lowest risk of developing brain metastases based on the genomic profile of the primary tumor. So basically, imagine someone who has a primary tumor or primary cancer. Based on the molecular underpinning of the primary tumor, we are able to predict whether this individual will have a high risk of developing brain metastases or lower risk. And this was a pan-tumor predictor. So it did not really matter what the histology of the primary tumor was. So it could be a lung cancer or breast cancer or other type of cancers. So this is pretty interesting, and we think it's very impressive and transformative, because what we think the next step would be is to take that predictor and apply it on some clinical trials. You may actually take that predictor and, let's say, I'm just here, theorizing. You take the highest risk patients of developing brain metastases and say, I'm going to look at frequent monitoring with brain imaging and to see if I can detect the brain metastasis early on, because it may make a difference from a patient perspective. And there are a variety of other elements that we could do. So we're very, very happy with this presentation, and we look forward to additional work that might come from this. Another one that is also interesting is looking at pancreas cancer patients and that have a mutation in the KRAS, but G12G as opposed to G12C. And I think there's a lot of, as we look at KRAS as an oncogene, now we're realizing that the where the particular mutation is might matter, and that might actually impact the type of therapies that patients have. We have a poster discussion on GIST. GIST is gastrointestinal stromal tumor, and we actually looked at the microenvironment, and we tried to look at a variety of, what is the molecular profile of various type of GIST tumors. So there's a lot of this. I think I don't want to go too long, but I'll summarize it in maybe a couple of buckets. I think this is probably the easiest way because we really can't do 42 abstracts, right? One bucket is we are very interested in predictive markers that might allow us to predict whether patients will benefit from a specific therapy. And we have actually an oral presentations on germ cell tumors that are looking at that. Then we have interest in prognostic markers. So are we able to tell based on our molecular data, patients that are going to do worse and those who are going to do better? Because that might tailor what you would do. And number three is, I would say, understanding the molecular profile of various tumors, whether these are rare or common ones, because sometimes knowing that might really help us to design the future therapies to help our patients affected with cancers. And the last bucket that we are in, again, there are many buckets, but I'm just trying to be very succinct here, is looking at disparities in molecular profiles and cancers and therapies. So as you know, that looking at the demographics of the US, there are Caucasian patients and non-Caucasian patients, and there's a lot of data that Caucasian patients undergo more genomic profiling than non-Caucasian ones, but we really need to figure out how we can improve on that and also understand the differences on the molecular level between various ethnicities and races.